Good morning, everyone. Dr. Spargas, congratulations about the meeting. I'm sorry I can't be with you because today I also have some workshops here in a meeting in Thessaloniki. Maybe next year we can plan it. I took the challenge to talk about tricuspid valve, and let me share my screen. Okay, can you see my screen?
Yes, go ahead, Kostas.
Okay, so in the next 10 minutes, 12, we will discuss about the patient selection for transcatheter edge-to-edge repair for tricuspid valve. So we will focus on the anatomic criteria, but we listened to very nice presentations before about tricuspid regurgitation. It is a very common disease. It can affect the prognosis of the patient. It can lead to biventricular failure. We know that severe TR, especially if it is functional ventricular, has a poor prognosis of these patients, and we should take into account the presence of tricuspid regurgitation in our patients. When we evaluate this valve, we need to use all the available modalities, not only echo. Echo, of course, is the first, has the first priority, because it can give us an evaluation of the severity of TR, the anatomy of the leaflets, the annulus size, the size and the function of the right ventricle, and the size of the right atrium. But if we want to evaluate the right ventricle better for the function and the size and for tissue characterization, we need to use the cardiac MRI as well. Cardiac CT is mainly used for patients that we will have planning for transcatheter tricuspid valve replacement. Transesophageal echo is not the best choice for tricuspid valve because we have thin leaflets. We cannot align our probe with the fast view of the tricuspid valve, and we know that tricuspid valve is an anterior structure. It's the distance from the esophagus is big, and that's why most consensus documents suggest to use the 3D transthoracic echo because it is superior to demonstrate the anatomy and the variations of this valve. We can achieve images like that where we can see the septal anterior and posterior leaflets very easily. And we can also appreciate all the variations that we have recognized recently with the 3D echo. We know that the tricuspid valve doesn't have only 3 leaflets. We might have 2, 3, 4, or even 5 leaflets. And 86% of the patients that will come to our echo lab will have either the normal 3 leaflets tricuspid valve or the variation with the 2 posterior leaflets, the P1 and P2, which is the 3B variation. This is the most common variation. Here you can see a huge gap of this valve with 4 leaflets and anterior septal and posterior 1, posterior 2. And with 3D echo, we can recognize other variations like this one with A1 and A2 leaflets, or this patient with septal 1 and septal 2. It's very easy with the 3D transthoracic echo. Classification of TR is also very important. We know that we have ventricular or atrial functional TR, but we also have organic primary TR cases due to prolapse, due to rheumatic disease or carcinoid, and we also have a specific subgroup of patients with implantable electronic devices. We might have patients with prolapse like this one, where you can see that we have septal leaflet prolapse very nicely demonstrated with 3D echo. But more than 90% of the cases have ventricular or atrial functional TR. It is very important to differentiate which is atrial, which is ventricular, because this will affect the prognosis and the adverse events of our patients. And there are some echo parameters that can help us differentiate what is ventricular TR, what is atrial functional TR, mainly the tethering, the size of the cavities, the tending area, the tending height of the leaflets. These are very important parameters to differentiate which is ventricular, which is atrial functional. For cardiac implantable electronic devices, we need to know the reasons why we can have TR at the end of the procedure. And according to this consensus document, we need to perform a routine transthoracic echo at the end of every implantation, because if we have a new TR that was not present before, then we have to consider of what was wrong in the implantation of this device. For severity evaluation, TR is more difficult than MR because we have a big valve. We have a valve that is an environment with low pressures. We have lots of variability of severity according to the respiratory cycle. And we need to use all the available tools from PISA method, from anatomy assessment, for inferior vena cava, the hepatic veins, of course, advanced methods like TOE with transgastric views for the location of the TR, the anatomy according to the transthoracic 3D echo, and vena contracta area are also very important. It is a multidisciplinary assessment and approach with different tools to evaluate the severity of TR. And of course, we know that severe is not enough as a term for this big valve. We have to use also massive and torrential with PISA method and vena contracta area, because we have found with transcatheter treatment that if we reduce the torrential TR to just severe, then these patients also have the clinical improvement. And that's why we have included this new classification into our clinical practice, but it's not yet into the guidelines. RV function is also very important. The standard 2D parameters are not enough to evaluate the right ventricle, like TAPSE and tissue Doppler imaging. We have to use the strain imaging as well in myocardial work. We have normal values that correlate very well with the CMR for RV function. And of course, 3D ejection fraction and volumes is the most accurate method to reach the volumes of cardiac MRI and have a nice estimation of the RV function and size. And we need to include all these parameters into our clinical practice. Apart from these, also RVPA coupling is very important, is an index of TAPSE towards PASP, the most commonly used, or we can also use the GLS. Okay, you can see me, sorry, I had a problem with my camera. Can you still see my presentation? RVPA coupling taps it towards PASP. The ratio is very important with a cutoff value of 0.4. If we have a high index, then these patients will have better outcomes after edge-to-edge repair. And there are some new methods that can include also the 3D echo to check the RVPA coupling. In my opinion, and according to these studies, we should measure this index every time we have a patient that goes for screening for transcatheter treatment. Transcatheter treatment has an indication of 2B at the current guidelines. Most patients should go for surgery, but the problem is that all these patients go very late for operation with already right heart failure, and that's why we have a very high mortality. For transcatheter treatment, we need to assess risk scores. This tri-valve score that includes atrial fibrillation, GFR, gamma GT, right heart failure, and LV ejection fraction has a better sensitivity, specificity in comparison to STS score or Euro score for detecting better outcomes and hospitalization in our patients after edge-to-edge repair. And all our patients should be symptomatic with optimal medical treatment with diuretics, volume overloaded, and we need to check the anatomy of the valve. We need to check the right ventricle. We need to check the pulmonary hypertension and organ damage, of course, for liver or the kidneys. We have a lot of devices available at the moment for implantation of or treatment, and we have an overlap of the indications for anatomic criteria for these patients. But we need at baseline, as we said before, to check the TR severity, the TR mechanism, the anatomy, the RV dimensions and function, pulmonary pressures, and the presence of left-sided valvular heart disease or LV function. Edge-to-edge repair is the most common method, again, like mitral valve. We know that it is effective, it is a safe method, it can improve the quality of life of the patient, it can lead to less hospitalizations and better survival. And we know from different trials that quality of life is the main result of this treatment, and we can have some survival increase in our patients as well. We have a sustained TR reduction after edge-to-edge repair and over the time. And we know that if we achieve at the end of the operation less than moderate of TR, then these patients have better prognosis and less hospitalizations. When we screen patients for edge-to-edge repair, there are some conditions that should go immediately to rejection of the patients, like rheumatic tricuspid valve disease, like patients with carcinoid and fibrotic leaflets with huge gaps, or patients with active endocarditis and vegetations. These patients should be rejected from edge-to-edge repair because it will be challenging and it will develop complications or high gradients or a suboptimal result at the end. But when we have routine cases that are screened for edge-to-edge repair, we need to check which leaflets are involved, if we have a good length of the leaflets, what is the gap between the leaflets, if we have a huge tethering, if we have leads, the location of TR, and horizontal right ventricle is also important, and if we have a good imaging quality. Most of the clips are implanted between anteroseptal leaflets according to TriLuminate study, and we can also go and clip the anteroseptal or posteroseptal leaflets as well and create a triple orifice tricuspid valve according to the jet location, of course, and the experience of the operator. The gap, the coaptation gap of the leaflets is very important. There is a cutoff of 7 millimeters according to some papers that says that if we have a gap of more than 7 and a non-central, non-anteroseptal jet location, we might have a success rate of the procedure of 0%. So we have to avoid patients with huge gaps, and we have to avoid patients with non-central or anteroseptal jet. On the other hand, if we have central jet or anteroseptal jet and a small coaptation, we can have a success rate of more than 90%. And the length of the leaflets is also very important. This ratio of leaflet to annulus index shows that if we combine the gap of the leaflets and this index, and we have a high index, which means high length of the leaflets in combination with low gap, then we can succeed an operation with low residual TR rates. If we have leads, but they are in the commissures in a good position, then we don't care because we have a good outcome. But if we have impinging of a leaflet or we have perforation, then this patient might be rejected from edge-to-edge repair. So overall, these are the parameters that will characterize a patient as green, yellow, or orange, red. And we shouldn't reject the patient from this method, but we should call it as a challenging case. We have this GLIDE score. It was recently published, which includes the gap, the jet location, the imaging quality, the chordal structure density, and the unfast TR jet morphology. If we use this GLIDE score, we can predict which patient will have success at the end of the procedure. And of course, as I said before, we shouldn't reject easily a patient from edge-to-edge repair because we can also repair complex cases with massive or torrential TR, with huge gaps, with more than 3 leaflets or devices into our way. But we should also know our limits. This patient was rejected from edge-to-edge repair because of huge gap. You can see that the gap between the leaflets is 14 millimeters. We have a huge right ventricle with a reduced ejection fraction and a wrong position of an apical position of this lead of the device that developed torrential TR with the triangular signal here, hepatic vein systolic reversal, and an inferior vena cava of 47 millimeters, huge RV with reduced ejection fraction. So we should know our limits and not treat all patients. So in concluding, we know that TR affects the prognosis of the patients. It is challenging to evaluate the severity and the anatomy of this valve. We need at least 3D echocardiography for the anatomy and the variations, and we might need cardiac MRI for the RV function and tissue characterization. And when we screen patients for TEER, we should include anatomic criteria, clinical criteria, and RV function into our assessment. And of course, we must be realistic. We will reduce hospitalizations, we will improve the quality of life of the patient, but not necessarily the survival. Thank you very much for your attention.
Thank you, Kostas, for your excellent presentation. It is clear that we must evaluate the RV volumes and RV function, ejection fraction before every procedure. Do you think that even with new softwares for 3D evaluation, transthoracic, I mean, of RV volumes and RV ejection fraction is accurate, or we must continue with an MRI?
Panos, thank you for your question. According to all papers that were published for 3D echo, ejection fraction correlates very well with CMR, with a variability of around 3 to 5% of ejection fraction, which is very low, you know better. But we still underestimate the volumes. So about function, I think we can be accurate with the 3D method. But for volumes, we still need the CMR. I don't know if from Dr. Sparias or Dr. Ninios, teams that have great experience in TR, if it is in their common practice to go for CMR in these patients. But I think with 3D echo, we can have an accurate assessment of the patients.
Okay, I agree with you. I try many times to measure the volumes of RV with 3D echo from transthoracic views, and I have different values in the same patients.
Imaging quality plays an important role. If you have a good baseline imaging quality, you can count on your images. But if the patient has poor acoustic windows, then CMR is important.
Yeah, yes. The important is that you must have best images. Okay, any comment? Dr. Sparias.
Kostas, hi, thank you for the presentation. I think the invasive echocardiographer so far had to give us an idea from the screening if that case will be feasible, easy, or difficult. But I see that now things become more complicated for you guys because with the advent of TTVR, the possibility to replace the valve transcatheterally with a VOC. Now you also have to decide when you do the screening if this patient is better suited for TEER or for a VOC. And so your role becomes more significant, and this is a question also to Professor Aggeli and to Vlasis, who may be online. Who will be the one to decide for a patient that is not very good candidate for TEER, which way to go? So this is just food for thought for also the next presentation. So it's not only easy or difficult case for TEER or unfeasible, but if you're not sure, you have to decide which way to go, and this decision will be very important because it will be irreversible in most cases.
Okay, thank you.
Congratulations for your presentation. May I ask you, atrial versus ventricular secondary TR, the difference is all in the prognosis, or you might have to plan a different procedure, as the size of the annulus might be different between the two of them?
Of course, the prognosis is totally different between atrial and ventricular, as it is in mitral valve. For planning the procedure, I think the anatomic criteria that we presented before are enough for deciding if the patient is suitable for TEER. So if we don't have a gap, if we don't have leaflets, if we don't have, for example, a location that comes from posteroceptal, then we don't have issues for edge-to-edge repair. And I'm not sure if we have very flattened leaflets, if this makes the grasping difficult for the interventionists. And this is something that the interventionists should answer. But in my opinion, if the anatomic criteria are met, we don't have issues for retinal functional TEER.
Thank you, Kostas. We have to move on.